This should be the beginning of the official recording of the Dr. Pearlman podcast with distinguished guest, Madeline Wingard, physician assistant, Alabama born. Did I get that right?
Texas born.
Oh, Texas born. Alabama raised?
Not even. I just went to school there.
She went to school in Alabama.
You're going to make the Texans not like me if you continue to push this Alabama nonsense.
No, seriously. Sorry. Yeah, she is not Roll Tide.
No, definitely not.
She's down with the Longhorns, the Aggies.
Sure.
Yeah.
I'm not going to, I exist in Texas. Let's just say that. I'm not a big sports fan.
Okay. That was going to actually be my next question.
Any Texan team, I'll cheer.
All right. Well, welcome and thank you for being here.
It's a pleasure.
I've been looking forward to not just chat with you because of your vast knowledge, which we'll get into a lot of, why you're here and how you can help provide value and some education to our patient base and our listeners. But also, me and Russ, who's not here at the moment, she got stuck in some serious traffic. So sorry, Russ, you are not the co-host of this podcast. But we speak a lot about food, a lot about nutrition. Mm-hmm. And today we're going to change it up. We're giving the old Uncle Charlie the 12-6 baseball reference for a curveball. And we're going to change things up. So Madeline, please introduce everyone who's listening to who you are, what you do, and then we'll get into what we're going to talk about.
So currently I am a physician assistant for a family practice, but I have actually served in various capacities in medicine. I've kind of taken a little bit of a journey through. I was very first a registered behavior therapist. I worked with children with autism. I went into people's homes to provide care. After that, I went back to school and I became a laboratory scientist. So I worked for a hospital lab. I really loved the hard science aspect of that, but I missed my patient care, so I decided to merge those two things, and physician assistant was just the natural next step. And hopefully I'm done because I've had a lot of education and I am tired of school. So, but I really, really enjoy my role as a family care provider.
Yeah. And for people that don't know, what does it take to become a physician assistant?
So it is a master's degree, but it is much longer than your traditional master's degree. We actually have more credit hours than most of the allied health doctors. So that would be like your doctor of audiology and things like that. But you get your undergrad, you have your prerequisites. You typically need some level of patient care interaction or direct one-on-one patient care before you are eligible for PA school. And then there's various entrance tests, whether it's the GRE or I think there's now something called the PCAT. Mm-hmm. I dodged that bullet, thankfully. And then you apply and you go through the process and you go to school. And then you have a period of didactic in-class training followed by hands-on training. And then you're sent out into the world to provide healthcare.
And am I guessing about right then? Is it maybe 4 years to a bachelor's? And then 3 years-ish in that kind of a program?
I would say 2.5, but we go to school 8 to 5 Monday through Friday.
Yeah.
Consistently. And you may have 1 week break or so between a summer and a fall, but you are constantly in school for these 2.5 years. There's a little bit of variation from program to program. So there's other PAs out there who are like, I did my program in X months. I hear you.
Yeah. There's the accelerated and the, BS degree, I'm
they
sure.
They exist. They're not nearly as common, but yeah.
All right. Similar to chiropractic, though. Similar, okay. Yeah, very similar. Welcome again. And one of the things I've been wanting to talk about for quite a while is this idea of that insurance has people's not best interests at heart, or even the fact that the people that have insurance is I want to use my insurance, right? People come into my clinic, and I'm a chiropractor where I do not bill any insurance in office. Mm-hmm. And we probably lose, 10 patients a month to just a phone call that says, do y'all take my insurance? Do you bill Blue Cross? Do you bill Cigna? Do you bill Aetna? And you work at a clinic that does accept most major insurances?
Yeah. In fact, I work in Colleyville, so it's actually fairly well insured. I think that our numbers were somewhere between 92-95% of our patients are insured, which is actually really high for a family practice, generally speaking. Yeah.
You said how many? 92?
In the 90s. That was what I had last heard. Yeah, that's an extremely high percentage of insured patients for any family practice patient population.
Yeah, and it's funny
lucky.
when I hear 92, the reason I was like, oh, wait a minute, how many was because, doing a little research for this podcast, it may be an insignificant stat, but I find it significant because I thought it was also lower just in the United States citizens here in America. 92% of people have some kind of health insurance, not necessarily like private pay, Blue Cross kind of stuff, but I thought that was high when I looked to see that the number is more like 60% have the typical I pay for, Blue Cross, Cigna.
So commercial insurance versus Medicaid and Medicare.
Yeah.
Okay.
It's being more like 60%. So that is quite a high number.
Yeah.
And I guess one of the things that we should just lead with is this. I'm going to tell a story. I'm going to keep it short. My audience knows I can get really long-winded. So I'm going to tell the story. And then I want you to kind of help interpret it. And so that people understand what they're up against when it comes to their choices of whether they use their insurance, if they opt out, and can they opt out to not use their insurance. So here we go. So gentleman comes into me with about 2 years of really awful neck pain and some tingling and burning in his shoulders. And I say, after your preliminary x-ray and I do my examination, we'll see if you're a good candidate for care, or, it leads to like a trial of care, right? So we look at his x-ray and right away I say there's not a good line in the what we call spinal laminar canal. And for me, I pay very close attention to spinal laminar canal measurement. And if it concerns me, they go and get an MRI. And he was over 50 years old. So already I'm like, let's go ahead and get a closer look to see if we're dealing with some kind of stenosis here. That wouldn't necessarily even make him contraindicated for care, but certainly chiropractic in the traditional sense. And he might need to kind of consult surgeon, at that point. Again, I'm a responsible guy. People that know me, if I think you need to go to surgery, out the door you go.
Right. So, ethically, do no harm, right?
Yeah.
First step.
So I sent him for an MRI. But he's like, can I please use my insurance? Can I please use my insurance? And I said, hey, probably I can get you a $300 rate, in today's economy. It's not that expensive. It'll be one and done. I'll get the report in my system and we'll rock and roll and we'll see where we go next step. I really like to use my insurance. Now, again, I'm going to be mindful of my patients, and especially the rapport I build with my patients. I want to be mindful of his concerns for his finances. So I say, you know what? Go ahead, bill it. So he goes to the place. They deny the claim, and then he postpones getting this MRI, postponing his care, dealing with his symptoms. And he keeps calling me and saying, the insurance, Blue Cross, won't call you, but they keep giving me the special number for you to call, and you're going to call and you're going to speak to the specialist to see if I can get approval. And it was weird. Like, I've just never had this experience before. The shorter version of the story is I decided, it's okay, lunchtime, I'm going to make the call for him. Let's find out what happens. An hour later, I'm finally done with it, and I get on the phone with, I believe, somebody who's a physician, and they're grilling me about the symptoms he has, what happens if he does or doesn't respond to care, what would justify the means for this MRI. And I'm over there like explaining it to them like the physician that I am, and we're doctors of chiropractic. We're actually like primary portal of entry providers in Texas, but because there's some step that they don't like, we can't, have this guy's insurance pay for his MRI. And what ended up happening was, I believe I ended up giving them the difference of the definition between like radiculopathy and radicular pain. And then she was like, oh, he kind of knows what he's talking about a little bit. And then I ended up doing one of those, oh, by the way, he does not have a pacemaker. Thanks for checking. As in, like, you want a contraindication for like someone not hopping in the MRI machine. And so then, of course, she kind of started sweating on the other side and was like, oh, yeah, of course, approved. That was the end of that interaction. But after going through that, I think it inevitably delayed his care about 3 weeks. I did send him to a surgeon for consult, and I haven't heard from him again. But the point was, like, he had such a great amount of stenosis pinching his spinal cord that the cord itself was being softened. I forgot the medical term for that. And he needs to make the decision that there's only one way out for him: live with it, get surgery. And now I'd like for you to kind of educate people on, like, why does that happen?
Okay, so the delay in care. First of all, I just want to say that I constantly joke with my patients that I think insurance is one of the original 7 deadly sins. Step 1, you don't take insurance because it is a huge hassle to bill, and you don't learn insurance in school. That is not something they teach PAs, MDs, doctors of chiropractic care. That is something you actually have to go to school for, like medical billing and coding. If you want to sell insurance, it's its own program. So this is sort of a mystery for even practitioners who have to figure it out as they go along. So a lot of private practice individuals choose not to take insurance because they don't want to have to hire somebody and pay that overhead. Which ultimately yields to higher costs for the patient, right? So you're able to keep your practice costs at a relatively low price because you don't have a whole bunch of extra overhead, right? So step 1 was he wanted to use his insurance, but he found you a provider who does not take insurance. So maybe that's a barrier for care for some people, right? It just depends. Some people's insurance doesn't even cover chiropractic care. The next thing is that, as you should have, you wanted him to get an MRI. And it sounds like what they wanted was something called a prior authorization. So a prior authorization is when we want to do an intervention or a medication or a diagnostic, like an imaging or something like that, that we think is necessary. And it's usually kind of expensive. And your insurance says, no, I need your doctor, your provider to prove to me why you really need this. And sometimes it's just a form that we fill out online and we submit, notes and things like that. And it could take the insurance anywhere between 7 to 10 business days to evaluate that. If you actually spoke to a doctor, and so I obviously have not laid eyes on all of the documentation or the questions that they put you through, but if they actually put you on the phone with a doctor, it sounds like they had you do a peer-to-peer.
That's what it was, peer-to-peer, yes.
So basically, a peer-to-peer typically occurs when a prior authorization absolutely they deny it. So kind of let me take a step back and explain this prior authorization process really quick, because I think it's super important that patients understand that I do not have control over what medicines or interventions insurance is willing to pay for. So you've got bucket number 1, and these are your meds and interventions that insurance will pay for willy-nilly. These are your blood pressure medications, your antibiotics. They don't ask any questions. I send it to your pharmacy and they just pay for it. Then you have like category number 2 or bucket number 2, and that's your prior authorization bucket. And these are usually things that are a little bit more expensive, like MRIs or maybe a weight loss drug or maybe a chemotherapeutic agent. And I have to submit to insurance a form that states why you need this and labs that support it, and maybe even many office visit notes. Some forms are super easy to fill out. Some forms are not easy to fill out. And to be honest, I actually don't do very many of these because I'm very lucky to work for a decent sized practice. So we have personnel whose specific job is to handle these forms because we are asked to fill them out constantly. Like I could not see my patients, the amount of patients that I see, and be able to handle this paperwork at the same time. It would be impossible. And then we have bucket number 3, which is no matter how much we cry or beg, the insurance just is not going to cover whatever that intervention is. But going back to bucket number 2, prior authorization. So I fill this out. It takes, 7 to 10 business days for somebody at the insurance to look at it. They can still deny. I can submit everything and they can still deny care. And that's where you then have to do like an appeal or maybe a peer-to-peer, which is where you go a step further and you actually have to get on the horn with a doctor that works for the insurance company, and you're doing your best to convince them why they need this and why the patient needs this intervention.
And all this time, patient is a lot of the time suffering.
Yes.
And is it fair to say that when the original denial comes in, that's not even a medical doctor or medical professional making that denial?
I'm not 100% sure on that, but my understanding is no. The initial person that is looking at this is typically somebody who's just working for the insurance company that is told there's a set of criteria that the patient has to meet. And if that patient doesn't meet the criteria, doesn't matter like the logic or whatever, it doesn't matter the original prescriber's thinking. If they don't meet that basic set of criteria, it's a denial. And then after that is whenever you get to use all your medical knowledge to convince the doctor, right? But yeah, probably not a medical provider reviewing that PA initially.
Can you share with everyone who's going to be listening to this the story you were telling me the other day about the diabetic who needed to have the insulin adjusted and what ended up happening?
Yeah. So very recently, I had a new onset diabetic patient. Came in, he's really thirsty, he's urinating all the time, so he is symptomatic. And there is a lot of pressure on family care providers to try to keep people out of the hospital because they say, and this is actually a metric that insurance measures us on. Like primary care practices get grades on how many times your patients go to the hospital or how fast you follow up with your patients after a hospital visit, okay? Even if it's not for a primary care thing. So I'm trying my best, and plus, being mindful for the patient's cost, I'm trying my best to keep people out of the hospital. So I start him on various medications. He leaves my office with samples as well so that he can start things that day. And then I have him follow up in 3 days because this requires really close monitoring. New onset, and I had no labs on him or anything like that. So I get labs to kind of get a picture of where we are at. Because a new onset diabetic that is symptomatic can be at high risk for something called diabetic ketoacidosis. Which is something that people get hospitalized for. So I follow up with him in 3 days. His blood sugar is lowering, but he's still very symptomatic. And so I have made the decision, and I get his labs back at that point in time. And I'm like, we need to go ahead and start you on insulin. And so I place the order for the insulin, and I even go ahead and submit a prior authorization. And it takes another 2 days before the patient reaches back out to me to tell me that insurance denied the type of insulin that I'd ordered because they had a preference for another brand. Both of them were long-acting agents that I had started them on, so they're fairly equivalent. It was just simply a price difference, which of course I don't know the prices that the medication is going to cost or what insurance has worked out with the pharmaceutical entities. Because sometimes they, I think, will make deals so that they can get certain meds for cheaper prices. I don't know. Actually, you know what? I can't really even speak to that. It's just very interesting to me that essentially agents in the same category, the insurance will have such a strong preference for one over the other. But I never know what that is. It's a freaking guess. So anyway, this patient has now delayed care, and we have Saturday clinics. So I had him follow up on Saturday with another provider, and he had not yet been able to get his insulin. He's getting even more symptomatic. And I had written in my note that if there is any increase in symptoms and despite blood sugar lowering, then he just needs to go to the emergency room and we need to get him appropriate care. And so he ended up going to the emergency room. My colleague took a look at him and was like, yeah, I mean, you're worsening. You're not getting better. Insulin really could potentially have staved off that hospital visit. Yeah. But yeah, there was probably a delay in him getting his insulin by about 3 days before I realized, or before anyone contacted me saying that insurance won't cover one, they want me to send in the other.
And speaking of do no harm, I mean, this is a case of, everyone within the medical community who's supposed to be doing no harm, who's taken that oath, are not, doing they're not upholding the oath.
Yeah, well, I'm pretty sure insurance agents don't have to swear that, just the providers. So but
it's funny, right? Because the finger gets pointed, everybody right. Doesn't want to have the accountability, oh, it's not my fault, it's not my fault, it's their fault, it's their fault, it's your fault, it's her fault. It's crazy because I know the pharmacist. Something happened recently where Jen, who's a nurse practitioner, mm-hmm. You know Jen, of course.
I do.
And so there was something where the pharmacist was on the phone with her saying yeah, no, we're not going to authorize this drug. Something like, can you give us the name of your supervising physician? Mm-hmm. And I don't know if they were preparing for a peer-to-peer based on this one case, because that never happened before. And I was very quick to look up that no laws had changed in the sense of that should have been authorized. But that one pharmacist was just not going to let this prescription get filled for a patient. And so, yeah, it just kind of brought me back to that too. So to elaborate onto that story, I mean barriers to
and going back to your original story, how long did you spend on the phone originally, or speaking with that peer-to-peer? How long did you spend?
That peer-to-peer took just about 1 hour by the time I finally got on the phone.
Imagine you had to do that for 10 patients in a week.
Oh yeah, no, that's why I have not allowed. if I thought somebody was in that deep of need for advanced medical imaging, or to be, dare I use the term referral, to get them to the right provider, there's no option for them to verify their insurance. Once I'm talking to them, I mean, I'm insisting and putting it all on the line, like you're in danger, like you go get this, test, you go visit with this person. Yeah.
I also want to kind of like circle back to your story, because you mentioned something about you told the patient not to use their insurance. You're like, listen, if you don't use your insurance, this is what the rate's going to be.
Yeah.
I think that this is also a really important point, because patients will come in and say, well, my insurance will cover, I have good insurance. Well, let's take a step back and really just talk about what that even means. So you pay your monthly premium, and that varies depending upon how much your employer covers for you. But let's say you pay, I don't know, $200 a month. I'm just pulling a number out of the air, okay? And then your deductible, we'll say, is $8,000. So what that means is that you're paying this premium, and that monthly premium does give you some benefits, some perks. So like, remember those meds back in category 1? They'll be covered, right? And maybe a copay at your doctor's office is only $25 to go see that doctor, right? But what it does mean is that there is not 100% coverage on your medical needs until you meet that deductible. And your insurance will outline the areas of deficit. So an example might be, maybe your visit is covered at $25 and they'll pick up the rest of it, but then they'll only cover 30% of your labs. So you go get labs done and your insurance doesn't cover all of them. They cover 30%, and then you're still stuck with a bill. Well, that goes against your deductible. So all of that racks up until once you've met like $8,000 of medical coverage, then they'll start covering basically at 100%, right? But $8,000 is a lot. It takes a lot to get to cover your deductible, especially if you have a high deductible plan. And many of my patients, their regular doctor's visits aren't covered at all. So they're paying their $200 premiums and then paying $120 out of pocket to come see the doctor. Yeah. So where being able to cash pay for things comes in is if you have a high deductible plan, or we're worried that insurance isn't going to cover anything at all, you typically get a cheaper price if you cash pay something. Now, it does not go against your deductible. So I'm going to use lab tests as an example. And I'm going to use my own dad as an example, actually. So fairly recently, my dad needed some lab work, and he actually sees Jennifer. His insurance only covers 30% of his labs until he meets his deductible. The lab that we use charges Max Health, my office, $3 for a very specific test called a CBC. It's super common. It's kind of what tells us about if you're anemic, or kind of a high-level overview of your immune system. It's a really, really common test. So we'll say $3. And then, but if they bill your insurance, they may charge insurance like $60. My office is not making money on labs. We don't make any money on labs. That's the lab and the insurance that are making money on labs, okay? So I knew that my dad's plan only covered 30% of his labs. So if there's a high chance that I did my math wrong here, but let's say it was $60 and they cover 30%. So that might be like $18. So he would be out of pocket for the rest. Or he could just say, I'm just going to cash pay and it'll be $3. Yeah. That's it. Because all we do is just slide over that fee that the lab charges us for a CBC or whatever. And so when you're looking at imaging, imaging may charge insurance, like any of your major imaging companies, they may charge insurance $800 for an MRI, because insurance is only going to pay a percentage of it anyway, and then they may not get the rest of the money from the patient. So, because if it's too expensive for the patient to afford, then all they're going to get is that chunk from the insurance, and that's it. So they up the cost under the concern that the patient may not pick up the rest of the bill. Yep. So, but if you cash pay and you don't use insurance at all, they're just going to give you a flat rate price. And this is really important, is only for patients who have commercial insurance. Because if you have Medicare or Medicaid, we're not allowed to offer or talk about cash pay prices at all. Period. Yeah. It's illegal. Yeah, I mean, it's just crazy. Like,
when I tell people, or I suggest to people to please just go in to get x-rays at the Dr. Pearlman price. And when I say Dr. Pearlman price, it's the agreement we have with a particular couple of facilities. And the reason I'm doing this is to be mindful of their money, because as soon as the radiology center who wants to verify their insurance, and this is much to what we were just talking about, they want to verify the insurance so that they can get paid through the insurance at a much higher rate. But guess what? They're not going to just, take the 100% accountability, like you, the patient, who then verified your insurance, who thinks your insurance has, best interest at heart, is going to send you a bill for 30%, 60%, 70%, whatever.
Whatever they choose not to cover.
And then they come and ask me, like, hey, whatever, why?
They get mad at you, right? The patient gets mad at you, and they're like, why did you order this really expensive test for me? And it's like, ma'am, sir, I did not make the price for this test, but it is necessary for me to give you good care, because you found out that patient had such severe spinal stenosis that, I'm not a chiropractor, but I'm assuming that there may be an element of danger for you to work on somebody with that level of severity, or maybe it's a waste of their resources. You work on them and it's not going to cause any improvement in their symptoms.
Correct, yeah. And
right?
that's also too, just because you said like danger, just because I'm a chiropractor.
Right.
Yeah, no, could it be dangerous? Absolutely, under certain circumstance. In this particular person, I would be wasting his time and resources.
Right.
Absolutely.
So you made that judgment call and you got the imaging, and you also didn't, you did not delay care, because another chiropractor might say, well, let's not go forward with the imaging, right. Or any other provider. This is not necessarily towards chiropractic care, but they may just say, well, let's just do a trial of therapy, right. No imaging first, and then the patient is still in pain. Now they're wasting time and money, and then they go get the imaging because apparently the trial of therapy is failing, and they find out that all along what they really needed was a different modality of care, like surgery or maybe medication or injections or whatever the case may be.
And funny you just said injections, because like a real common occurrence in particular, you see this a lot with like orthopedic, is the person comes in that probably does need an advanced scan, but maybe through experience the doctor knows that they cannot get that authorized right away, and they start off with that waste of time, we'll just call it what it is, trial of care of injections and or therapy, that they are wasting time and resources. And time's our most precious commodity, whether entrepreneurial or not. And that person needed that advanced scan to get to what the inevitable.
Many insurances will require that you do physical therapy before they'll cover imaging of the lower back. And there's also, and I will say this, like, there's evidence-based medicine, there's guidelines that state if a person has back pain for a short period of time, imaging is not indicated unless it persists for maybe greater than 6 weeks. I forget the exact number. But so you come in and you're like, man, my back's been hurting for 2 weeks. Well, did you have any trauma? Did you fall? No. Okay, well then imaging's not indicated, right? Or are there any red flag symptoms? Like, have you had any fecal incontinence or urinary incontinence? I'm asking these questions. And if we look at you and are like, okay, well, imaging's not really indicated at this time, it's not that we don't want to help you. It's just the fact that these evidence-based guidelines do exist for a reason, and that imaging is unlikely to change our plan of care. But let's say you hit 6 weeks and we're still having this pain, this discomfort. Now you meet the criteria for me to do imaging. So I get an x-ray. X-ray looks fine, right? Really, if we want to see a lot about the back, we need an MRI. Yeah. And I'm like, all right, let me order an MRI. And then insurance says, won't cover, hasn't done a trial of physical therapy. And now you need 6 weeks of physical therapy.
And we both know, I don't know the exact number, like everyone in this room knows, X-ray, or they should know, X-ray will only pick up on something that's, let's just call it like a mass, something foreign, a lesion. 10% maybe that like a studied radiologist can even pick up on. You go the CT or MR route, now you're going to be seeing 90% of like what you need to see to not miss.
And X-ray is inherently limited. You're just going to see bony abnormalities for the most part, and if there's anything impinging or moving the bone, you can gather some information, but there's nothing like the clarity of an MRI.
Right. And everything I'm suggesting, and like your story, when it came to like someone, whether they're diabetic, whether they need chemo drugs, whether they congestive heart failure, kidneys, whatever it is, chiropractic, if I'm concerned about terrible stenosis or a mass or a lesion in the spinal cord, there's nothing like an advanced scan to like sort of cut the line as I always say. I'm like reverse pyramid guy, you know?
Yeah.
Like I want to go after the biggest thing first and then work our way down from there.
You know, there's actually that's such a hot topic right now too, because there's been some articles that are like Allied Health and APP. I don't know. Are you under the Allied Health umbrella? Is that what they call you? I don't know. But doctors of chiropractic care, APPs like nurse practitioners and PAs, they order more imaging. And there was an article that was saying that increasing the number of imaging or laboratory or diagnostic testing that is ordered is driving up the cost of healthcare. And I call bullshit on that.
Yeah.
Can you please, you told me the math earlier.
Yeah.
Can you please tell me per month what we calculated?
I love this. Yeah. So the way we did this was we said there are, I believe this is going to be right if, no fact checking needed, but if you want, go ahead and fact check. 200 million Americans pay for commercial health care. We pay into it a month. I believe the average is $340 a month for a premium from those Americans. That comes out to a company, so we'll just call them the commercial companies, each monthly guys, make $68 billion.
Right.
Monthly.
And you're going to tell me that we can't do imaging.
Yeah.
Because it costs too much money.
Yep.
The amount that insurance companies are making is increasing per year, significantly higher than the amount that your providers' salaries are increasing. So people love to say, oh, it's your providers that are making healthcare more expensive, but it's not. It's the insurance companies. Why are they allowed to take such a big cut? If all of us collectively are putting our money into this plan so that way we have coverage, should a health need arise, what right do they have? They're literally just serving as bank accounts for our money. What right do they have to take such a massive percentage of this fund and put into their own pocket? They don't have any right to that, in my opinion, right? Now, I mean, I don't know, maybe a business analyst could come in and say what right they have, but that's not me. I'm here from a healthcare provider's perspective. And it makes me livid because I believe firmly and fully that healthcare should be accessible for people. And this is just talking about commercial insurance. This isn't even talking about Medicare or Medicaid or the uninsured patients or all of the rest of the people that are having to pay into the healthcare system.
Absolutely. Yeah. No, it's really, you hit on some real wonderful points because, I mean, look, it's so easy to be like, it's a scam, insurance, corruption, but in reality, I'm sure if we dug deeper into the numbers, and no, I am not I'm not an analytics, numbers, stats guy that would take the time. But if I wanted to, I could, to find out that I'm sure there's plenty of people within these bigger commercial companies, again, excluding, government, Medicare, Medicaid, the amount of money they probably take home a month or the amount of money they're able to disperse to their offices, employees, and their charts and graphs and whatever far exceeds the reimbursements that go to not just the doctors, but the facilities that are taking care of the patient. And imagine the patient suffering who couldn't get a approval for we'll just even say $1,700, $1,800, $2,000 set of tests or imaging. It's disgusting. And it's one of the things that's really making Americans suffer, which, by the way, on that note, I'm going to give you a quill because I did a little bit more research. This should make people sick. I'm no, guy that thinks like, socialize, medicine is like the answer or socialism is some kind of answer. We don't want to have to go there. But in the UK or in, Canada, not the same thing, obviously, where there are these socialized medicine, free healthcare, free, meaning healthcare is a absolute right. You walk into a doctor's office, you walk into a hospital. Yeah, we get it. I don't care if there's a wait. You are getting the care you need. They will prioritize, right? Like if you show up trauma, well, somebody's hurt worse than another one, that takes priority. Babies die at a pretty significantly, less rate there than here. And we're supposed to have the best healthcare and all the stuff.
I would like to share a story if you don't mind.
I love
I
stories.
actually went to Portugal last year, and I am so fascinated with the concept of quality of life in other countries because, we're so full of the American dream, and I'm not here to bash America because there's I love my life here. Okay, so there's that. But I'm so fascinated in how people view their political system or their medical health care or whatever. And so I had this lovely tour guide, and I was just badgering her with questions, and she was so nice about answering all of them. But I was asking her a lot of questions about like their health care because it is free, right? So she was telling me it took 2 months for her to get her daughter in for her school physical so that she could participate in a sport. And if you miss that, she would not, if she had missed that appointment, she would not have been able to get her daughter in to play that sport, right? She wouldn't have gotten her physical done in time. And I was telling her, how much time I get with my patients, and she was like, she was having a series of medical issues, and she said that her doctor only ever spent between 5 and 7 minutes in the room with her, and they're so stressed and they're so overwhelmed because there's so much more access to healthcare because it's free, so everyone can access it as they should, but there's just a lack of providers in total that she ended up paying out of pocket for essentially like concierge medicine there to help diagnose and figure out what was going on because her visits were leading nowhere. They were just saying like, oh, it's menopause. It's menopausal symptoms. Well, actually she had Addison's disease, which is her adrenals were not making the corticosteroids and the things that it needed to function properly. So she couldn't get out of bed because she couldn't stand upright because she's so dizzy.
Addison's disease falls on the list of things that you may need medicine for to keep you alive.
Absolutely, or certainly to keep you functioning, right? Yeah. So it took her spending her extra money. Her taxes are higher to theoretically pay for her health care. So it did take her to spend extra money before she was able to get the care she needed. Now, wait, let me flip this narrative on its head. So I have a friend or an acquaintance who's there, and we went and had lunch. And his mother had ovarian cancer, and she was able to get care immediately and for free. This massive surgery that led her to be hospitalized because there were some other complications too, and all of her chemotherapy and radiation, she got it all taken care of. And as you know, medical debt is one of the most common reasons for bankruptcy here in the United States. That is a situation that would have made someone bankrupt. But in Portugal, this woman was able to get care and not go bankrupt from it. And then another tour guide that I was talking to about this, because I pretty much badgered them all with the same series of questions, was telling me that on one of the tours, somebody did a dive that they told them not to do, and this guy didn't listen, and he bashed his head, and he went unconscious, and they had to call essentially like a care flight, a helicopter to come out and pick him up. Do you know how much that guy paid?
Sounds like it's going to be $0.
$5. $5 USD.
Okay.
Yeah. I mean, that might as well be $0, right?
Yeah. And he didn't have to wait 2 months.
And he didn't have to wait 2 months, right? Because it was a medical emergency. Obviously, couldn't wait 2 months. So as you can see with that sort of model of healthcare, there are a ton of pros, but also some cons too.
Yeah. And I was going to ask, when you had mentioned about the mother and the girl for the physical, yes or no, there is a private sector in Portugal? Because of the standardized nature of healthcare, that does cap the salaries that the providers can make. So if they want to make more money, or maybe they just want to be able to spend more time with their patient, or they don't want to be so rushed, then they can choose to practice this private medicine. And they essentially are like cash pay. You see something very similar here in the U.S. It's called concierge medicine or functional medicine. These doctors typically do not take health insurance, which means they don't have to subscribe to the rules that health insurance binds us to. And you pay out of pocket for the service, maybe a monthly fee or something like that. Yeah. I guess you can classify me as a concierge, a clinic.
Potentially, although I will say that a lot of, I do see, the line between concierge health is typically, and then, someone who's just a cash pay person, is that concierge health typically bucks the system in that fact that they spend a little bit more time with the patient. They may run a few more tests than are necessarily evidence-based indicated. That doesn't mean that it's wrong. It's just maybe that they have a hunch and they're able to pursue it a little bit more. Or maybe they're looking for something.
Yeah.
That kind of circles into like, what am I allowed to look for? What is insurance willing to cover? And unless you have another question, but I do want to touch on that too.
No, go ahead.
So, let's say you come into my office and you're like, I'm real curious as to what my vitamin D is. Well, that's great. I'm a little curious too. And they're like, well, can you run the test? Well, I can run any test. I can order anything in this world, but will insurance cover it is the question, right? So I typically have to have codes to get it covered. And codes are, we assign a number and a series of letters to each symptom. So like high blood pressure, the code for that is I-10. You code it enough, you start to learn them, right? So my patient's like, I want to run a vitamin D. And I'm like, and what are our symptoms? They're like, symptoms? Like, well, if you don't have symptoms, then insurance won't let me run it, or you're going to get a bill for it, or you can cash pay. So as long as the patient's not like Medicare or Medicaid, they can cash pay, right? No big deal. I don't have to have a code. So then I'm like trying to I can't coach someone into having symptoms, but I'm like giving examples like, do you have fatigue? Is your sleep poor? Do you have osteoporosis? Like I'm looking for reasons to be able to get this code covered, or to get this test covered. And vitamin D is just one example. There's also like testosterone, or let's say you want to look at inflammatory markers, but you don't have rheumatoid arthritis or a known inflammatory disease, but there can be benefit. And that's why concierge medicine doctors love to run inflammatory markers all the time. There can be benefit to monitoring your inflammatory markers. It's just not like real hard and fast benefit. So technically insurance won't cover it a lot of the time. And then like prescribing medications. So sometimes there are things that we will use quote unquote off label. So on label is the FDA approved use, right? Let's say you have depression. And I want to give you Wellbutrin, which is an antidepressant medication, right? That's FDA approved. But let's say you have ADHD, but you don't want to be on a stimulant. Well, there's plenty of data that suggests that Wellbutrin actually does a goodly bit to improve focus in patients with ADHD. So I will prescribe Wellbutrin maybe as off-label, even though it's not FDA approved for that, to help the patient because they have these symptoms and they're looking for another route to fix it. And I know I can see your little chiropractor eyes squinting at me because you're like a lot more holistic and there's so many other things that you can do, but this is just one example.
No, well, what really was happening is I started smiling and I had to fight the urge to laugh because I was picturing that Key and Peele skit where one's the doctor and the other one's the patient. He wants a medical marijuana script and he's trying to, say like, hey, I got to have a reason to be able to prescribe you, medical marijuana. And the guy's just not picking up on what he's telling, so he's just hurting every chance he gets to get his script.
Right, he's saying don't have that, don't have that.
I don't have anything that you're suggesting that I could possibly have, but of course, in classic Key and Peele fashion, he's like, but I have AIDS. It's like, oh God, it's not going to get you what you need.
Right. So sometimes we're tearing our hair out because we're trying to help the patient, but like the patient's not helping themselves. But anyway, so, something that's like generic like that is typically not too expensive and insurance will cover. But maybe you need an off-label use of a medication that's a lot more expensive. And I think that it is an appropriate, like my medical judgment and training has decided that this is an appropriate strategy to pursue. Well, insurance just may deny it because they want to. They can. They don't want to pay for it. Or another really good example is Zepbound, which is a anti-obesity drug. It comes in many doses, and you typically start at a low dose, and you work your way up until, we're seeing mild to moderate appetite suppression, minimal side effects, and then maybe we plateau right there at that particular dose. There's no requirement that we drive to max doses, right? Well, I recently had a patient who is extremely sensitive to this particular medication, and we started her on the 2.5 dose, and we moved her up to the 5 milligram dose after an appropriate amount of time, and it was too much. It was way too much for her. She was not eating, and that is not acceptable because not eating is not good for anybody. And so we bring her back down to the 2.5 dose, and then her insurance says, you can't be on this dose because it's an introductory dose. I'm like, those are suggested guidelines by the drug manufacturers, right? But the drug manufacturers cannot tell providers what to prescribe, right? They can give us guidelines and how to prescribe it, and they can tell us information about how it was studied, but they cannot tell us exactly what to prescribe. So they give these guidelines, these suggested recommendations, and it seems like the insurance is like taking that as truth. So they said, we'll only cover 30 days of the 2.5. But I would like her to be on the 2.5 for maybe 3 months, you know? And what's so interesting is that the 2.5 and the 5 milligram dose cost exactly the same amount. There is no difference. It's just the insurance is sticking their nose in my clinical prescribing practices and telling me what I can and cannot do. But they're not even medical. They're not licensed to make those decisions.
And it brings us back to the age-old chiropractic quote, I don't want insurance to dictate your care. And what's funny is people who really have gotten a handle on how to bill insurance in any profession, but a lot in chiropractic, love to bash chiropractors when we say that kind of stuff because we don't want to deal with that. But imagine, you having to do that with multiple patients, multiple times a day, multiple times a month, and what that means to your mental health, let alone your patient's frustration.
Well, I would see less patients so very fortunately, again, like I have staff that does a lot of the back end work for me that frees me up to see more patients. Yeah. And as we all know, there's a deficit of healthcare providers in the United States. Again, in DFW, we're very lucky because it's a little bit more saturated, but generally speaking,
we got to make some of these chiropractors go away to make it less saturated.
Right. But spread the love,
Russ, why aren't you laughing back there?
She forgot that you made a joke.
No, I know. That was me. I just wanted to break the ice by saying, yeah, Russ Powell's in the background. She's the producer today. Oh, yeah. She's producing. Sorry. Go ahead. Sorry.
No. But very fortunately, I have like staff that supports me in that. But I would see less patients if I had to do that, because at the end of the day, like, this is my job. Like, this is my 40-hour work week or whatever you agree to work within your job's description, but like, this is my job. It's not my entire life. So if I'm going to commit 40, 50 hours or whatever is decided, then there's going to be less people that are helped if I have to spend a ton of time doing back end work. And you also have to think that you have to pay that person. So someone who has a degree in medical billing and coding, I'm going to be honest, I have absolutely no idea what these people make, but I'm going to assume it's somewhere between $40,000 and $60,000. Okay, and we're going to make that assumption because it's a degree. Like, these are people that have a skill set. So you would have to pay a personnel that you are asking to submit all of this stuff, and so that's coming out of your pocket, and then you would have to raise your prices because of that, because now you're having to cover their salary. And here's another really crazy story. Insurance can just choose to not pay their bill. So there was a doctor at my practice who their notes their visits hadn't been reimbursed by one particular insurance in over a year. Like, the insurance was finding reasons to not reimburse this provider. And they'll do that. I mean, obviously insurance can't read every single note ever because that would just take too much time. But they will often pick, certain notes to read and make sure they meet all of these different criteria. And if there is one little bit missing, they can reject that note and say, we will not cover that visit.
Oh, yeah. Early on in my chiropractic career, I was doing things called, oh God, why do I want to say PRP? But PRP sounds like platelet-rich plasma. But there was PIP, personal injury protection.
Oh, okay.
And I got the first claim reimbursed. And the subsequent, I believe, 8 or 10 claims that I submitted were rejected because of pick your poison code that the insurance is just it's just wrong. Mm-hmm. Nah, it needs a modifier. The modifier. I haven't said that word in 4 years. So, I learned quickly, it's just crazy. You could, whether you're paying somebody, like you had mentioned, so you can bill, I mean, they will sit on them, the denials. And this is adding up. So 1, you're not making money. 2, it's not even working towards their deductible. 3, it's a shit show slowing everything down. And
Let's talk about those codes really quick, because it's so wild what insurance is what insurance has said that they will cover for certain things. So let's say someone comes in and I look at their tonsils and they're huge and they are inflamed, and I say they have tonsillitis and I code for tonsillitis, okay? That is a clinical diagnosis. Itis just means inflammation of. Tonsils are tonsils, okay? So tonsillitis. I'm looking at their tonsils. They got tonsillitis. I want to run a strep test on them, okay? And if I'm not on my A game, maybe I don't code throat pain because I have 1,000 codes that I've already thrown in there. Maybe I just forget throat pain. Insurance won't cover that strep test because I didn't put throat pain in there. Even though strep is a reasonable underlying pathogen for us to investigate for tonsillitis, if I don't put pain and throat, that very, very particular code, they're not going to cover a strep test. Now, that happened a lot more when I was a newer provider because I didn't understand the game as well, and I just didn't have that knowledge. I would say that now I don't have to open nearly as many charts and correct the codes. But in the beginning, it was certainly a learning curve to make sure that I got all of the right codes in for insurance coverage on things. Because why wouldn't they cover it for tonsillitis, but they'll cover it for pain and throat? It doesn't make sense, but they've made that choice. It's not intuitive.
Hey, CEOs got to get paid.
Right? So now, and that delays reimbursement for us as healthcare providers because my billing and coding is like, hey, that's not going to get covered. We need to rectify the situation. And so then I have to go in and like fix it. And then we resubmit the claim, right? And if you are a single shingle provider, which is what I call anybody who just has their own private practice and they work for themselves, then, you know, that's your direct livelihood. I get a salary, right? So I'm getting paid regardless. Of course, my boss will get mad at me if I don't fix the codes in a timely manner. But at the end of the day, I'm still going to make the same amount of money. But for people who are single shingle providers, that's a big deal.
All right. So here's the deal. We're at 50 minutes.
All right.
And we're going to be getting close to wrapping it up just because we know people's attention spans and we are considerate of your time, all the viewers and listeners, even though you can't get this information anywhere else because we put it out there in a digestible way on the Dr. Pearlman podcast. We're not trying to appease to the Andrew Hubermans and the Joe Rogans of the world. We are trying to help you out there. If that's you, me, her, you, them. Okay, here's the deal. For those of you that know me, we got to figure out to give some solutions. So can we just quickly talk about GoodRx, single care?
Yeah.
Like things like that. Who is like, I guess like straight up, I'm asking like, who can use that?
Anybody can use GoodRx, and I love GoodRx so much, and I recommend it to my patients all of the time. GoodRx is like an aggregate for coupons. So drugs go on sale just like groceries, clothes, and cars do. And you type your drug in on GoodRx and it will tell you the sale. So sometimes insurance won't cover something that is old and generic and should be cheap. So you go onto GoodRx. Let's say acyclovir. If you have a cold sore and your doctor gives you acyclovir, right? And for whatever reason you go to purchase it from the pharmacy and they say that'll be $30, please. And you're like, wow, that's kind of expensive. You can go onto GoodRx, type in the name acyclovir, and pull up a coupon code for the pharmacy that you're at. And it might knock it down by 80%. So then you may only pay $5 for your script.
And do you have to go to the pharmacist and say, or whoever's at the desk there and insist? Are they going to try to sway you to like run your insurance card?
So that is the tricky part. I've tried this myself because I don't like to do things or recommend things unless I've experienced them to the best of my ability. Yeah. So I did go to CVS one time knowing that they don't take my insurance. I have to go to Walgreens. I had an antibiotics in there. And I was like, let's just test out this GoodRx thing. So I went, I said, can I get my antibiotic? And they're like, that'll be $30-something. And I was like, well, I'd like to use a GoodRx coupon. So they did not mention GoodRx to me. I had to make that request. Now, I played dumb and pretended like I just knew peripherally about GoodRx, that I didn't know how to use it. And I will say the tech or whomever cashed me out, they walked me through the entire process. They helped me get online. They helped me find the drug. So they were really helpful in that way. So I just tell my patients, you don't have to know anything about it. Just say, I'd like to use GoodRx. And they will help you. But you have to know those words. I had another example of this utilizing one of my sister. It was like my sister's medications. You know, we like to make our own family guinea pigs. And that tech was really helpful. And they were like, hey, this doesn't look like it's covered by your insurance. You want to check GoodRx to see if it is a little bit cheaper. So that particular person was very, very helpful. I can only imagine that's probably not what her boss is telling her to do because they make more money if you don't use GoodRx. But I would say be prepared. Know the phrase GoodRx. And just know, though, that if you choose to use GoodRx, that does not, you're cash paying and it does not go against your deductible.
All right, very cool. Yeah, and that's big. And I hope also everyone that's listening knows the next thing I'm about to say is from really just the bottom of my heart, and I want to make it very clear, sort of my stance. If you've listened to this podcast and you've listened to all 54 minutes thus far, it sounds like we're bashing insurance and saying insurance doesn't have your best interests at heart and insurance is evil, which there's a lot of truth to that. However, I would never advocate that people in the United States do not have health insurance in the event of an emergency. And what I want to do is elaborate a little on that. And then, of course, Madeline, feel free to add on or elaborate. But I feel that if we can just go to a provider of our choosing, or we end up in a situation where we are going to have to get medical intervention of any kind, that we should pay out of pocket to get the best rate, thus being our own advocate, and really understand that really our insurance is going to be there for our emergent, not even urgent, but emergent need. Because regardless, if you pay your, copay, you're going to have to pay towards your deductible.
Right.
You're going to have to get those bills in the mail and everything that we alluded to in this podcast. And just know that in the end, it's like the difference between $7,000 or $8,000 in care. Example, I paid over $7,000 out of pocket before my back surgery. And, I'm very thankful that it all ended up working out because the surgeon that I wanted didn't do, insurance, what should I say? Not a region, the hospital or facility that they were at, like they had to, be in network, so to speak. And, ultimately probably saved me, $200,000 or money that I, speaking of number one cause of bankruptcy in America.
Right.
It's not because we're all just out there being irresponsible, buying the nicest Jordans and jewelry and expensive cars. It's because things happen and you get in a spot and it's, healthcare a lot of the time and you go broke. So please, guys, when you're listening to this, understand you're an individual who makes your own choices.
Right.
Please be responsible with your choices.
And I think that just to add on to that I saw recently some an insurance bill on a person who had to have their gallbladder removed. And ultimately, they only paid $500 out of pocket. They had very good insurance. And their entire hospital stay plus their surgery and everything was about $30,000. So they had insurance and that helped them greatly. So I am definitely not advocating to live without insurance in this particular world. But I do think that there are some ways that you could save money and that you can actually arm yourself to make sure that you're never in a space where you're paying out of pocket for things that your insurance should be covering. So number one, you need to find out what major hospitals in your area take your insurance. Because if you go to a hospital that doesn't take your insurance, you may not find out till you're already there. And if you're in really critical condition, they can't move you to a hospital. They have to treat you there. So you need to find out so that way you can advocate and go to wherever your insurance accepted. So just have this baseline knowledge of who are the providers in your area, and if you have a major medical emergency, what hospitals accept your insurance. Secondly, always double check GoodRx to make sure that you can't get a better price. And this is mostly useful for generics. Your branded drugs are going to be expensive no matter what. And then thirdly, if you do have an urgent issue and your primary care office is closed, and don't underestimate what primary care can do for you, but your primary care office is closed, go to an urgent care. And I will repeat this, an urgent care is not the same thing as a freestanding emergency room. If you see freestanding ER or anything that says emergency room on that, they will charge you emergency room prices. Even if it's not connected to a hospital. It's very confusing for the patient, and I totally understand that. And there's actually a whole big ethical debate about how they should be representing themselves. But going to an urgent care is actually going to significantly decrease your costs compared to going to an emergency room. Now, if you're in severe intractable, that means not fixable abdominal pain that's not being fixed by anything, you can't lay down, you can't eat, obviously go to the emergency room. But if you have a really severe urinary tract infection that's just causing you a lot of pain and it's midnight and there's a local urgent care that's open, or maybe 7 o'clock at night and there's a local urgent care or something like that, that's going to be a cheaper option than going to the emergency room.
And thank you, by the way. That's actually a point that I hadn't even considered, is researching and looking into local hospitals.
Be prepared.
Because imagine going to the hospital and you have insurance and they don't, the hospital for emergent care doesn't take your
That
insurance.
happened to my little brother. He was in a terrible car accident and was internally decapitated. He is fine. He survived. Thank God. But he was flown to Children's Health in Dallas, and he was in such critical condition that is exactly where he needed to be, but they didn't take his insurance.
Wow.
And there was nothing to be done in that situation, but that's just a really good example of how,
A short, I guess, short version of this answer. My question coming is, did the insurance remedy it? Or are you guys stuck with $500,000 in bills?
Well, Children's Health Network was really, really wonderful, and there was a lot of donations and scholarship and things like that.
Okay.
And so, no, we're not stuck with that. But the reality is some people are.
Yeah. Wow. All right. Well, I could sit here and talk for hours, but what I'd love to do is sit down with you again at some point and talk about something else if you liked this interaction and the setup today.
Yeah, absolutely. It was a great time.
Okay.
An hour flew by.
Yeah.
So fast.
And
I have so many opinions, so many things to say.
Okay. No, this is good. This is what we do here on the Dr. Pearlman podcast. We talk about things that need to be talked about. Mm-hmm. We share things that need to be shared, and we have a good time doing it. So before I say goodbye to everyone, and Madeline Wingard.
Madeline Wingard. Mm-hmm.
Thank you so much for sitting down with me. And for those of you that don't know how to find us, it's Dr. Pearlman TV. That is Dr. like Dr. Pearlman TV, all over the internet, YouTube, Instagram, Facebook, all the good stuff. And the Dr. Pearlman podcast, just to throw everyone off, for Apple, Spotify, and YouTube is how you can listen to this podcast. Many episodes over the last 3 years, guys. You knew there was a break in there. If you don't, just listen to some of my content. And guys, thank everybody for tuning in. And last thoughts, anything that you want to say to the people out there before we sign off?
Man, just really pay attention when you sign up for insurance. Be aware of what is covered, what is not covered. Just spend that 2 or 3 hours that it might take to get your affairs in order. And by say affairs, just understanding what you're really signing up for. And I think that can help you utilize your insurance for you and not let them take advantage of you.
Amen.
Yeah.
All right. It's been a pleasure.
Thank you so much.
Everybody, until next time. All right.